So I'm going to go over systemic therapy for gastric cancer. So generally, what are we looking for when we're looking for gastric cancer? So as Dr. Schaefer already talked about, we do an upper endoscopy and get biopsies, and then we'll have a pathologist come in and take a look at those biopsies to diagnose the cancer. And then the next step is staging. So generally, your oncologist will order some type of imaging. So generally like a full body CT, chest, abdomen, pelvis. So full body CT, sometimes a PET scan if sometimes the CT can't detect the cancer. A PET scan can be better. Staging laparoscopy, like Dr. Pimiento just went over, if there's no evidence of metastatic disease noted on the CT scans, and then an endoscopic ultrasound might be useful as well. So sometimes in the early stages, some cancers can arise from the junction of the esophagus and the stomach, and those can be treated as gastric cancer. And then depending on the stage, the treatment options are different. So usually endoscopic procedures can be helpful, surgeries. So like Dr. Pimienta said, removal of part or full stomach, and sometimes cytoreductive therapy or intraperitoneal chemo as well. Chemotherapy with or without targeted therapy, immunotherapy and radiation are generally the mainstay of treatment for patients with gastric cancer. Okay, so what is systemic therapy? So when you're diagnosed with gastric cancer, your oncologist will talk to you about starting some type of systemic therapy. So that's not just chemotherapy. So chemotherapy is the one term that we all think about when we hear about treatment for cancer, but there's other agents as well. So targeted agents, which are generally the newer things that we've been looking at in the last couple of years, targeting specific types of mutations or antibodies. Immunotherapy is generally new. It's been new in the last couple of years, and we'll focus on that more so in this talk. And then antibody drug conjugates as well. So what test should your doctor order? So you've been newly diagnosed, you know your stage. So if you're stage 1, 2, or 3, a lot of times we want to order some type of biomarker. So MMR and MSI testing are very important because these test results help to determine if some type of immunotherapy is more favorable for your treatment rather than chemotherapy when followed by surgery. And then your doctor can also order some type of blood work to help monitor your treatment after completion of your systemic therapy. And then stage 4 cancers, so metastatic disease, again, you want to look for your MMR or MSI status. A lot of times your doctor will order HER2, which is the same protein that's found on cancer cells and breast cancer as well, can be also found in gastric cancer. PD-L1 is another very important biomarker that helps to determine whether or not immunotherapy is more beneficial over chemotherapy. Newer biomarkers like Claudin 18.2 are being looked at for possible new targeted therapy. And your oncologist should consider some type of next-gen sequencing. So pretty much looking at the entire genetic evaluation of the cancer to look at the genetic sequence. And then your doctor can also, again, consider some type of liquid biopsy or blood test to help monitor your treatment after, and sometimes even, again, to look at the genetic makeup of your cancer. So the new paradigm for treatment of stage 4 cancer. So again, like I mentioned, you want your doctor to look for MMR deficiency or even MSI high. So pretty much these two biomarkers help to determine whether or not specific chemotherapy such as immunotherapy such as pembrolizumab have been shown to have more benefits over chemotherapy for your treatment. And then HER2 positivity. So if you're HER2 positive, then trastuzumab is the treatment of choice when added to chemotherapy with or without immunotherapy for your cancer. And this goes for both stage 4 or even unresectable gastric cancer. And then patients who are HER2 negative generally benefit more from chemo alone. You can have chemo plus 2 other forms of immunotherapy added on, which are nivolumab and pembrolizumab. Okay, so the principles of systemic treatment. So essentially when we're looking at stages 2 and 3, Our goal is to offer chemotherapy and to be able to kind of shrink your tumor cells so that we don't really see that cancer anymore. And that's essentially the goal. So the goal of stage 2 and stage 3 is to offer some type of treatment and cure. So it's not sure whether or not how treatment is going to affect your survival or not. But again, the goal with stage 2 and 3 is to offer some form of cure. And then chemotherapy has been shown to improve survival in patients who receive treatment after surgery. And then stage 4, our main purpose is to do no harm. So we're not trying to hurt you by giving you treatment, right? We are just trying to focus on getting your cancer under control. When we're talking about stage 4, we're talking that there is no cure, but again, it's trying to get it stabilized and under control. Usually stage 4 patients, when we're talking about treatment, you want to make sure, most patients we want to make sure are in good physical health, their labs are good, and that the treatment that they're going to get is a feasible option for them. So for first line treatment of systemic chemotherapy, generally you'll hear your oncologist mention some form of regimen that includes either 2 chemotherapy drugs or 3, depending on how medically fit that patient is. So usually you'll hear them say some type of fluoropyrimidine or a platinum agent. So if you hear cisplatin, oxaliplatin, then you know that this is part of the base regimen as to what chemotherapy you're getting. And then we've seen that combination regimens actually offer better improved survival compared to when you're just offering a single agent. Again, if you're HER2 positive, then your oncologist will probably end up adding trastuzumab to your current chemo regimen. And then if you're PD-L1 positive, then nivolumab is usually added as first line treatment to your chemo. If you have metastatic disease or if you have progression of disease after your first line treatment, then as of late in the last couple of years, your oncologist will probably start adding this medication called ramucirumab, which is a specific VEGF2 receptor blocker, and it's been shown to have survival benefit in patients when added on top of paclitaxel, which is chemo. So when we're talking about chemotherapy, there are side effects, and a lot of these side effects you probably are aware of. So generally the most common side effects we're talking about are like nausea, vomiting, hair loss are a big one. Usually patients will have loss of appetite. You'll see that your oncologist is following your labs to make sure that your counts are not dropping. And a lot of times patients just feel very fatigued, tired, and then sometimes neuropathy can develop as well. So that's also a big side effect. But again, a lot of these side effects are able to be treated. So just tell your oncologist when you're getting treatment, because sometimes your treatment regimen, the doses of your chemotherapy regimens can be decreased to help mitigate some of those side effects. And then it'll help you tolerate it better. And then just remember that when you have stage 4 cancer, it's a marathon and not a sprint, because we're trying to help you get the disease under control, and we're not trying to hurt you. So immunotherapy, what is it? So essentially immunotherapy, what it is that it is a form of cancer treatment that helps boost your body's immune system. And when we're talking about immunotherapy, you'll hear different words. So oncolytic viruses, CAR T cell is pretty new. Some type of immunotherapy, like pembrolizumab, nivolumab are like the most common ones that you'll hear, and then sometimes monoclonal antibodies. So how does it work? So essentially what happens, normally what should happen in your body is that your immune cells, which are the cells in blue, should be able to detect a cancer cell, which is the little bad guy in green. So when they're able to detect the cancer cell, they should be able to say, hey, you're bad, we're going to get rid of you. But that's not what happens. Essentially, your immune surveillance is off the rails. It's not working right. And the reason for that is a lot of times cancer cells can secrete certain proteins and that prevent your immune cells from detecting that cancer. Essentially, there's like a blindfold or a curtain in front of your immune system that helps prevent them from detecting the cancer cells. So what the purpose of immunotherapy is that immunotherapy will help bind to those certain proteins that your cancer cells are secreting and block them, essentially lifting that blindfold or that curtain that's present in front of cancers, in front of your immune cells, and help your natural immune system help detect and fight that cancer cell. So for example, we have PD-1 and PD-L1. So if PD-1 and PD-L1 can't interact with each other, then your immune cells can detect that cancer cell and attack it to help treat it. So essentially, like pembrolizumab and nivolumab, we're trying to prevent those two proteins from binding to each other so that your lymphocytes can essentially attack the cancer cell. One thing for sure is that patients who are less fit, meaning that they are not as they're not as fit, meaning that their ECOG score is not very good. Those patients don't do very well with immunotherapy, and you can see that in the blue line versus the red line. So immunotherapy, just like any other drug, has side effects. And a lot of times when we're talking about side effects with immunotherapy, we're talking about some form of inflammation in the body. So the symptoms can be a little different than chemotherapy. And these are a lot of the symptoms that patients will get admitted for, that as a hospitalist in the hospital that I'll help take care of. So the most common ones that you could present with are lung symptoms. So inflammation of the lungs, patients present with like shortness of breath, difficulty breathing, requiring oxygen. So pneumonitis is a big one. A lot of patients develop diarrhea after getting immunotherapy. So colitis is another big one. Sometimes the immunotherapy can attack your heart, can cause myocarditis. It can attack your liver. So essentially, any major organ in your body can get affected. And the mainstay of treatment for this would be steroids. So how do you generally monitor after treatment? So after stage 2 and 3, your oncologist will generally order some form of imaging every 3 to 6 months for the first 2 years after treatment completion. Every 2 years, generally, you'll get some form of, again, CT scan or imaging up to 5 years. And then after 5 years, your oncologist can kind of determine how they want to proceed with surveillance. Your port is generally kept in for at least the first 2 years after completion of treatment. But then again, that can be removed based off of your conversations with your oncologist. And then for stage 4, you'll usually end up getting some type of imaging every 2 to 3 months. And then your oncologist may consider some form of biopsy to determine treatment options if the treatment that you're on is not working very well. But that's pretty much it. Thank you.